Greetings, ladies and gentlemen. My name is David Lewis, and I will be presenting how the U.S. healthcare system affects access, quality, and equity in America. We'll be going over the providers of healthcare in the U.S. system, healthcare settings in America, and purchases. Introduction to healthcare delivery systems. System definition. Healthcare delivery systems are networks of people, institutions, and resources that deliver services to target populations. The U.S. system is complex and fragmented, characterized by proliferation of payers, providers, and settings of care. System design. Systems address what services for whom, how delivered, at what cost, and with what results. Equity issues. Inequities arise, creating disparities by race, ethnicity, socioeconomic status, and geography. And understanding the impact. The disparities are long-standing. Understanding system design is key to reducing them. Providers, roles and equity implications. Healthcare workforce. Nurse practitioners, physician assistants, nurses, pharmacists, therapists, social workers, hospitals, community health centers, long-term care facilities, and public health agencies diagnose illness, manage chronic conditions, coordinate care, and engage in quality improvement initiatives. Barriers to care. Lack of specialists and limited insurance networks, geographic barriers to specialized care access, implicit bias in clinical decision-making processes. Equity solutions. Team-based primary care and medical homes, community health centers with cultural responsiveness, safety net hospitals with sliding fee scales. Navigation services. Allied health professionals provide key education, navigation, and adherence support. Language access. Proactive outreach and language services for vulnerable populations effectively. Value-based care. Equity dashboards help refocus attention and incentives on reducing disparities. Settings of care, access, quality, and trade-offs. Primary care and medical homes. Key access points for prevention and chronic disease management effectively. Adapted services to community needs reduce avoidable emergency visits. Patient-centered medical homes improve access, continuity, and cultural responsiveness. Emergency and hospital care. Safety net providers for uninsured and underinsured patient populations. Routine emergency use signals failure in primary care access. Post-acute care exhibits disparities in referral patterns and availability. Healthcare setting spectrum. Ambulatory and retail options. Increased convenience but distributed unevenly by geography and don't always provide comprehensive, continuous care. Telehealth innovations. Addresses barriers of distance and time but requires broadband, devices, and digital literacy capabilities. Post-acute care settings. Essential for recovery but exhibits disparities in referral patterns and service availability across populations. Purchasers and financing. Who pays and affects? Healthcare purchases. Purchases include primary employers and individuals buying commercial coverage plus government programs like Medicare, Medicaid, CHIP, Veterans Health Administration, and the Department of Defense. The relative contribution of these sources changes over time, with Centers for Medicare and Medicaid, CMS, tracking national health expenditure data. Private insurance challenges. Employee-sponsored individual market insurance have significant gaps in affordability issues affecting vulnerable populations. Coverage gaps for part-time and low-wage workers without employee benefits access. Individual market has high premiums and cost sharing, unaffordable for many families. Limited affordability, even with subsidies, leave many people underinsured despite coverage. Government program variations. Medicare, Medicaid, and CHIP provide essential coverage but operate with varying effectiveness and state-by-state differences. Medicare helps older adults but disadvantages low-income beneficiaries through cross-sharing requirements. Medicaid and CHIP expansion varies by state and provider participation limits. High out-of-pocket spending leads to care delays and medication non-adherence issues. Payment model impact, fee-for-service, capitation, bundled payments, and value-based arrangements shape care delivery incentives and patient access patterns. Centers for Medicare and Medicaid Services track national health expenditure data changes. Payment models influence how providers deliver care and prioritize services. Vulnerable populations are hit especially hard by downstream effects of cost barriers. These are the references that were utilized in making this presentation. We have academic sources. This presentation draws from peer-reviewed research, government reports, and authoritative healthcare policy sources to provide evidence-based analysis of the U.S. healthcare delivery system and its impact on access, quality, and equity. We have government reports, Agency for Healthcare Research and Quality, Centers for Medicare and Medicaid Services. We have academic publications, Institute of Medicine, National Academies of Sciences, Engineering, and Medicine. We have the textbook source, Delivering Healthcare in America, a Systems Approach. These comprehensive textbooks provide foundational knowledge on healthcare delivery systems. I hope you enjoyed, and I thank you very much, and have a blessed day.